4 years now. Look, so the major, I've put a few points down, but the main access issues I had, if I had to pick it, was access to people with low prevalence mental health issues. So these are people who, obviously need help. They need help quickly. To get that done quickly can be a real challenge at times. And even if you try and access private psychiatry, often private psychiatrists have a waiting list. CAT team can sometimes be a bit hard to get hold of and to respond to. And so all those difficulties means that we're sort of trying to sort out what's best for the patient. It's a little bit easier if they're really, really acute suicidal. You can send them off. But it's that group in between, they can't wait quite long enough for weeks to see someone, or if they can actually afford to see someone, as opposed to them waiting for the public services to actually collect people. So that's, to me, a real challenge. Once they get into the system, it's a bit variable. Sometimes, so I had a patient who had bipolar who took a long time to recover. So the first time she went into the public health service was actually discharged reasonably quickly, but then had or bounced back, I suppose, within probably 6 weeks. Second time round, they picked that she was, needed a lot more support and was placed into the PARC program. Absolutely fantastic, wraparound care, followed her for about 18 months, really tracked her very well, and she's had a really great outcome. I actually saw her today, and she's looking the best she ever has. So, there seems to be this two-speed system. When you get into it and you get into all the services that you need, it works really well. But trying to get that can be really, really difficult. And of course, that's out of my control. I don't have anything I can do about that. When it comes to low prevalence mental health issues, the remuneration's actually not really great. So if you're using things like mental health item numbers, you can use reviews for up to 3 times in a year. But they don't offer you much more than a level C anyway. Now, we're a non-bulk billing clinic, so I think a lot of people don't come here, but we do have our, I can call them favourites, but where we actually bulk bill some people because we know we've been seeing them so much and it's starting to become a real burden. The other issue that I'm seeing a lot, just because of where we are, is the impact on students. I don't know if you'll notice, but the students seem to be under more and more pressure every year. And we see a lot of people presenting with mental health issues, depression, stress, anxiety. And often when they're overseas students, they don't have a support network here. And so they really don't know what to do. And then trying to find an appropriate health professional who knows their culture can be very, very difficult because often their ideology is so different. And then if you try to use a phone interpreter service around that, can be very difficult because I'm not quite sure what's going on, what people are saying. But I've noticed certainly a surge in mental health issues with students, and that does worry me. So I think the way our universities are going, it's very much pushing people through, but they're not actually doing a lot of wraparound care. So student health was a big one that when I've mentioned access to private psychiatry, and even though we have the 291, often a lot of psychiatrists won't use it anyway. And so it's a matter of trying to find someone appropriate. And the challenges, can be quite different. So, I used to be a clozapine prescriber in my own practice, my other practice. But I had a patient follow me, and she got off her clozapine and was doing really well, and actually had a baby, and was doing really well. But postnatally, about 2 or 3 months, started to be aware that things weren't going as well, and she picked it. And so, right, we'll use psychiatrists, and so. But the postnatal psychiatrists felt it wasn't their role because she'd been previously a clozapine patient. So they thought it was more general psychiatry, not postnatal. But when you phone up with the general psychiatrist, you say, well, 3 months postpartum, they say, well, no, that's postnatal. And so then you get this toing and froing. Now, at that stage, the clozapine service actually said to us, if she ever needed to go back, all you had to do was phone and get them in. I can tell you, 6 calls, 3 letters. It took us 3 months to get her into the service. Now, in that time, I'm starting her on major antipsychotics. Of course, I can't prescribe clozapine, but it was a tough time for both her and me. I'm thinking, I want support. Eventually got back into the clozapine service, got given the appropriate medication, and doing really well. But there was 3 or 4 months in between there that was just not fair. Not fair on me, not fair on her. And I think we do need to address that, almost like a no wrong door approach, because I think that's an important thing. Out-of-pocket expenses, both when you see psychologists and psychiatrists, you think in this area it's not an issue, but it can be. And so people will often delay seeing specialists because of that. And sometimes they'll see them once or twice and then stop. We do get patients who come here every so often for a further opinion because they may have seen 2 or 3 psychologists, they've seen the GP, they're coming, look, we're not getting better. I find it interesting that the way people approach is that if you have a mental health problem, you see a psychologist, they seem to have forgotten that there is a thing called psychiatry. And so sometimes psychiatry adds another dimension. And in fact, you can sometimes work out they've been treated for the wrong thing. And so sometimes seeking that expert help can be a real boon. Now, other times it's not. But, I think we need to get away from being psychology-centric to a more broader approach in terms of mental health. One thing I do find a real struggle here is drug and alcohol services. It's the stigma of referring someone who's relatively well off into a drug and alcohol service. That becomes too much. And I don't know what we can do to reduce that stigma, but it is a significant barrier for people accessing services. And we do see alcohol and other drugs here that have actually caused significant health issues. And look, I know the services are there, I know how to access them, but certainly some of them can be quite confronting when people turn up, and I've had patients turn up and when they've walked into the waiting room they've gone, oh my God, so we do need to address that. Now, my other doctors mentioned 2 other things. So we see quite a few people with IVF. We have a lot of mums who are trying quite late and will go through multiple cycles of IVF. The psychological damage and things that they go through is actually enormous. Yes, they do offer some support with social work and psychology, but not anywhere near as what I think that they need. And if they've gone through 6, 7 cycles, that sense of failure, that sense of what next. I mean, it can be really quite difficult for them to get over that because they drive with wanting to have a child, but every time they go through a cycle, this is it, I'm going to have a baby, I'm pregnant, but then it doesn't happen. And it's just this continual up and down. And the last one was postnatal depression. You can get access to postnatal psychiatry really quite well, but it's all the other services, about parenting, about sleep, about all those things, because we often have families here who are isolated from extended families, so they don't have parents that they can turn to, brothers and sisters, so they're often isolated by themselves. And they don't get that networking support, and it'd be great to see, I suppose, a non-psychiatric psychological network for women who are actually experiencing postnatal depression, because we do see it quite a lot here. So that's where I'll stop. That's sort of my brief overview. If you have any questions, happy to ask. Thanks. Yeah.
So the impact of gaps in services, you sort of mentioned how hard that was for you. Do you think there's a vicarious trauma happening for doctors?
Oh, look, I think what happens is we then try and fill the gap and try as best as we can. And so sometimes we extend what we do a little bit beyond what we're comfortable with. And so, then we're feeling a little bit nervous. And so we often get the patient back a little bit more often. And sometimes it's just nice to have a diagnosis and a plan. And then say, right, we've got this, let's do this. And the 291 was supposed to offer that. But again, this is a once-off visit with psychiatry. But, again, it's very hard to get. I'd love to see better access to psychiatry sort of in an urgent sort of way. I know we've talked about that at the PHN, putting that into the mix, but again, it's a completely different sort of funding. But not so much here, but certainly in my previous practice, access to public psychiatry. I grew up when we had psychiatry as a separate system. Now, I think it's a great idea that they tried to meld them. But in that process, they lost a whole lot of funding and they lost a whole lot of public support. So there's no, I've got rheumatology outpatients, cardiology outpatients. I don't have psychiatric outpatients, and that makes it really, really difficult. So I either go privately or have to be bad enough to actually be admitted. I don't have anything in between, and that's really tough. So does that answer your question? Yeah.
Do you think there's a burnout effect, though, that could happen to doctors?
There are some doctors who attract or have a lot of people with mental health because they have an interest. And yes, some of them do get a little bit bitter with the system. And I've certainly seen that. And, certainly in our young, I teach registrars. And I've had registrars, we did a lot of refugee health experience, vicarious from what the refugees were coming in, but then trying to access services when they're on a community detention order, where you can't go publicly by definition, really, and you can't go privately. So where do you go? And we had a young one that we tried to get into Origin, and they didn't want to know because so it's not our responsibility. Then you try the captain, they said, no, it's not our responsibility, and the poor registrar was just beside us trying to access services. Again, a no wrong door approach. We need to be able to refer somewhere with confidence to know, yes, they will accept it. So back.
Yeah, I'm just wondering what impact do you think the rollout of the NDIS has had on your mental health patients?
Look, I must admit, I haven't dealt with the NDIS a lot. A lot of people having trouble getting access. So I've had one chap who's, I think, applied twice, and he's debating whether he really needs to apply a third time. And it's not just mental health. So I've got a lady with MS, 64, technically should be under the NDIS, but they've knocked her back. So I'm not quite sure how it works. So I'm not sure where to go next, but it's not so much so I really can't comment on that one. It seems a bit of a problem as far as from where I sit.
2 years ago, we had the Child Abuse Royal Commission, and a lot of institutions were asked to take up the redress scheme. And part of what was provided in the redress scheme was mental health counselling. And I'm just wondering, do you have any patients who were, made submissions to that commission or were suffering from child abuse in an institution, and how you cope with them?
Yeah, so I haven't, I'm not aware of anyone who actually did a submission. So I've only been here about 3 years. So it's often when you've been in the area for that, so when you get to that 5-year mark, you tend to collect a lot of people because suddenly people start to think, oh, well, they're staying around. And so this is when you often start to collect people with multiple problems and chronic problems. So far I haven't come across people that actually made a submission or who, in fact, were institutionalised at that point in time. I've certainly had people who've experienced abuse. And again, most of the services around for abuse is not too bad, although I can be surprised at the length of time it can be to see a face-to-face counsellor for someone who's experienced domestic violence and or sexual abuse. That just surprised me. They do it a lot by phone, and then at some stage down the track they'll see face-to-face. I'm not quite sure if that's really the appropriate model, but again, it just seems problematic in access. So, I mean, from where I've been, I think there's basically a lack of leadership within the mental health community and an absolute lack of funding. I think that when we went to the one system, I think the funds got ripped out of the mental health system and it was never funded appropriately. And I would like to see that correspondingly go up again. But that's my personal view, sort of sitting on the sidelines. But I've just seen it, grey beard, so I've been around for a while. I've seen the gradual loss, do I say degradation? Yeah, I say degradation of mental health services over the last 20 years. And it's just been so hard to see because, I think even, I was on the front of Audehm talking about my concerns about mental health back in the 90s. And here I am in front of you guys talking about my concerns about mental health, and nothing's changed. So, yeah.
The statistics for people attending a GP who present with mental health issues or concerns. Can you make a comment about the training of general practitioners in the area of mental health?
Look, certainly when I went through, so I can't comment about now so much, but certainly when I went through it was zero. But you know, in my day, we had a thing called a rotating residency program, which you're allowed to pick up special interests. And so one of the things that I did was psychiatry. So some of you may not remember, but I was actually at the Rundle in Mont Park for 6 months learning about psychiatry. You know, it was an interesting model, and I know it had its flaws, but certainly I learnt a lot about low prevalence mental health conditions in that and how to respond acutely when people. Do I think it needs to be made more robust? Absolutely. And certainly here we see a lot of high prevalence mental health issues. Where I used to work in Broadmeadows, it was far more skewed to the low prevalence mental health issues. And that's because I think it was a community health centre and we were a clozapine prescriber back then. So, but yeah, no, I you know, they technically is supposed to do postgrad some extra studies to access the mental health rebates. And again, you know, but to me, it's about how do you engage GPs in a very positive way to say that this is something that's really good, interesting, and keep it going. So, yeah.
Another question, if I can, the war on drugs. This is an area that has methadone programs.
Yep.
And I know because I used to live between where they drop off the train and where they're going to get their methadone. I can see people constantly going to get it. Now, I believe that having the war on drugs is not helpful and that we need to treat these people for mental health issues. There's now a safe injecting room trial in the area. I think it's finished.
No. So the injecting room's still there and it's going well and it's been really successful. There is a bit of pushback, which really worries me. And what worries me is that the model itself is not looked at as expanding because there are other areas that we really could do with injecting rooms. Look, I love the model. I think it's a great model. I think decriminalising the whole process is a great way to go. In my previous practice, I was a methadone and Suboxone prescriber, and it's always surprising, you know, people are just ordinary people who have real issues, and I think if you can sort of tackle them in that sort of, you know, medical social model, it's much better than certainly going down the whole police thing. The only thing I think also sex workers have a similar issue because that's all monitored by the police and it's not actually considered to be a profession as such. And I think that causes its own issues too, but that's another thing.